Welcome to this explainer. Today, we're diving into the fascinating step-by-step detective work that doctors use to methodically treat anorexia. Now, just to be clear right out of the gate, in this specific clinical context, we're looking at anorexia as a severe general loss of appetite, rather than the psychiatric eating disorder. It's an incredibly common yet surprisingly complex medical presentation. I mean, think about it. How exactly does a doctor take a symptom as vague as, "I just don't want to eat," and turn it into a rigorous, actionable medical plan? Well, today, we're going to look directly at the clinical management protocols to see exactly how they tackle this whole shebang. Okay, let's dive into this clinical pathway. We've got 5 key areas on the agenda today. Step 1 is the rule-outs, then we'll look at the medication toolkit, diet and lifestyle interventions, managing extreme cases, and finally, what happens when treatment fails and we have to investigate. Let's get right into it. All right, starting us off with step 1, the rule-outs. Before building any sort of treatment plan to stimulate appetite, a doctor first has to act like a detective. They need to verify that the patient isn't actually suffering from an underlying primary condition that's just masking itself as appetite loss. So, step 1, rule out jaundice. Step 2, rule out fever. And step 3, rule out anemia. It's really just a massive process of elimination. If a patient is feverish, or their liver isn't processing bilirubin correctly, which leads to jaundice, or if their blood is lacking healthy red blood cells, their body naturally shuts down the desire to eat. It does this to conserve energy or fight the illness. So you can't just force an appetite if the engine is literally on fire, right? Now, what happens if they do hit a positive on that initial checklist? Let's say the patient actually does have anemia. Well, the protocol specifically dictates a direct intervention. Doctors will start the patient on an iron supplement called Cap-Otrin, and I want you to notice the duration here. They take 1 capsule daily for 3 whole months. It's a great reminder that fixing underlying deficiencies isn't just an overnight magic trick. It requires sustained, targeted treatment to rebuild the body's baseline stores before a healthy appetite can truly return. Moving right along to our next section, let's open up the medication toolkit. So once those primary rule-outs are handled, it's time to actually stimulate the system. Take a close look at this multi-pronged approach, because it really demystifies some of the dense medical jargon. As you'll see, doctors aren't just handing out one magic pill. They're using a really comprehensive toolkit. We've got Neurobion, which is an injectable vitamin B complex given on alternate days to just boost cellular energy. Then there's Activate, acting as a general tonic. Next, we get to the direct appetite stimulants like Prectin, which contains cyproheptadine, taking half an hour before meals. They even use tablongefene, an antihistamine, and T-unionzyme for digestive enzymes to make sure the gut can actually process the food. And perhaps the most surprising one, Tabzental is prescribed as a single stat dose. Why? Well, it's an antihelminthic, meaning a deworming tablet. The protocol assumes that parasites could be quietly stealing the patient's nutrients, causing the loss of appetite in the first place. It is a brilliant cover-all-your-bases kind of strategy. Next up, let's talk about diet and lifestyle interventions. Because, let's face it, medicine is really only half the battle. Implementing proactive lifestyle changes is absolutely crucial here. The protocol outlines a very specific foundation: good food rich in proteins and fresh fruits. But because eating is so difficult for these patients, they rely heavily on highly concentrated nutritional aids. We're talking prescriptions for proteinules, 2 teaspoons of that mixed in a glass of milk twice a day, or Threptin biscuits. Beyond diet, the protocol actually mandates regular exercise to naturally stimulate metabolism and hunger. And I've got to say, I find this last point completely fascinating. A change in climate, especially for convalescent patients. Simply getting out of a stagnant environment can literally be a clinical recommendation to aid physical and mental recovery. How cool is that? But just as important as the positive additions to their routine is what the patient must immediately subtract. To truly heal the body, the protocol is absolute. The patient must stop smoking and stop drinking alcohol. No exceptions. Both of these habits can severely suppress appetite, they irritate the gastric lining, and they directly interfere with the very medications we just looked at. You just cannot rebuild a house while you're simultaneously setting fire to the foundation. Now, let's shift gears and look at managing extreme cases. So, what exactly happens when standard first-line treatments just aren't enough to trigger an appetite? Well, in extreme cases, the patient's digestive system is often far too compromised to take things orally, so doctors escalate the stakes significantly. They bypass the stomach entirely, starting with a 1,000 milliliter intravenous infusion of glucose saline. This immediately tackles dehydration and provides a critical baseline of electrolytes and fluids straight into the bloodstream. But as we know, fluids alone aren't enough. The body needs fuel, and it needs it fast. To rapidly force energy into the patient's system, they also utilize a highly concentrated 25% IV glucose solution, specifically administering 4 ampules. Think of this as a rapid rescue intervention. When a patient is severely depleted, this highly concentrated dose of sugar gives the brain and organs the immediate chemical energy they need just to keep functioning, buying time while the medical team works to resolve the underlying anorexia. And if the patient is still struggling, the protocol introduces a very serious pharmacological escalation. As a last-line measure, they bring in an anabolic steroid, specifically inch-decaterbalin. The protocol calls for 50 milligrams to be administered intramuscularly every week for 3 weeks. Now, anabolic steroids are incredibly powerful hormones that promote muscle growth and stimulate appetite. It's a real heavy hitter, used specifically to reverse the severe tissue wasting that happens when a patient hasn't taken in enough calories over a long period. Which brings us to our final section, when treatment fails, investigating. Despite all of these tools, the vitamins, the diet changes, the IV fluids, and the steroids, medicine is ultimately unpredictable, and as medical detectives, doctors always have to prepare for the absolute worst-case scenario. So the natural question this raises is, what do doctors do if there is absolutely no response to this intensive treatment plan? Like if the patient's appetite simply will not return? Well, this is a massive red flag. It means the loss of appetite is not just a simple deficiency or a temporary slump. This lack of response triggers a deep investigative phase, where doctors cast a massive net hunting for hidden, serious conditions. They'll run extensive blood panels checking hemoglobin, serum bilirubin, blood urea, and serum creatinine to fully evaluate kidney and liver function. They analyze urine for bile salts. They order chest x-rays, specifically hunting for tuberculosis or malignancy, meaning hidden cancers. And for elderly patients, they go even further, utilizing gastroscopy and abdominal ultrasounds to physically look inside the digestive tract for tumors or blockages. In this scenario, the symptom of anorexia has transformed into a siren warning of a potentially life-threatening systemic disease. To wrap up this explainer, isn't it just incredible how this highly structured protocol transforms a seemingly simple loss of appetite into a rigorous, life-saving medical investigation? We've seen how it leaves absolutely no stone unturned, starting from basic vitamins and lifestyle tweaks all the way up to advanced diagnostics for hidden malignancies. It really makes you wonder, the next time you or someone you know simply loses their appetite for a few days, what complex, unseen mechanisms might your body be trying to signal to you? Thanks so much for joining me on this